Hi, this is Dr. Mark Poole, and this talk will cover the pathology of multiple sclerosis. This is the first part of two chalk talks that will discuss multiple sclerosis, with the following talk of several white matter disorders that may be clinically considered with multiple sclerosis in the differential diagnosis. So let's start off with a couple of epidemiologic and clinical considerations of MS. MS is more common in women than men. The male or the female to male ratios range depending upon different studies that you look at. The peak age of onset is 20 to 40 years. Onset before puberty or after 60 years of age is rare. An important point is the prevalence, which varies geographically. So you can see areas of the world that have a higher incidence than in some other areas of the world. And there's been a lot of speculation about this, and searching for viral or other environmental factors to explain this difference in the prevalence of the disease. This is a table that shows some of the symptoms that are found with MS and distribution of how frequent they are. MS commonly presents with weakness, paresthesias, and sensory loss involving one or more limbs, optic neuritis, diplopia, incoordination, and vertigo. It's less commonly associated with these other symptoms. Particularly note a classic sign, which is Lermet's sign, which are painful electric shock-like sensations that shoot down the back or limbs upon flexion of the neck. MS often initially pursues a relapsing and remitting course, but can be progressive from the outset and tends to eventually become progressive after initial remissions. The interval between relapses is variable, and the latent phase between the onset of disease and the first relapse can be many years. I'm not going to pretend to be a neuroradiologist, but I wanted to show these images because I do have gross pathologic changes which correlate with the MRI images. So these are some classic findings that one can see on MRI imaging in MS. The top two panels show multiple hyperintense periventricular and subcortical white matter lesions. These are the plaques as visualized by MRI. The middle panel here, B, shows a T1 weighted image that shows low intensity lesions in the periventricular sites, indicative of so-called black holes that correlate well with disability scores. The long panel here is a longitudinal section showing infratentorial brainstem and spinal cord plaques. The bottom panel here shows the preferential location of plaques favoring the posterior spinal cord. So we'll see gross images to reinforce this as we go along here. The gross appearance of the plaques in MS have a grayish-brown appearance or discoloration and appear slightly depressed. So the arrows here are pointing out some typical plaques which vary in size and shape as well as locations. We'll look at some typical locations coming up on the next slides. One typical location are multiple plaques that are found in the deep cerebral gray matter. Again, these appear as gray-brown patches. You can see them here in the basal ganglia and in the thalamus. Here's plaques in a very characteristic area adjacent to the superolateral angles of the lateral ventricles. Higher magnification view of one of these plaques in this location. This is a low-power microscopic view with a myelin stain showing one of these plaques in the superolateral angle. So here's the lateral ventricle, and here's the plaque that's adjacent to it. In a myelin stain, the myelin is stained sort of a blue-purple color, so the absence of staining indicates one of two things. Either it's gray matter, which is what I'm outlining here, or there's demyelination. And so these pale areas are showing the absence of myelin stain. So keep that in mind as we look at additional sections. Another characteristic location is the optic chiasm and optic nerves. And so this shows a lesion in the optic chiasm. Microscopically, we see a section of optic chiasm, and again, note that there's a peripheral crescent where myelin is preserved, and then a large plaque in the optic nerve, which shows the absence of myelin. And the plaques appear exactly the same in the spinal cord. They're usually slightly depressed and have a gray-brown discoloration, this time on the surface of the spinal cord. This is the posterior surface. Again, remember that the plaques tend to prefer the posterior columns of the spinal cord. This is another myelin stain, a low-power microscopic view, again showing these plaques in the base of the and tegmentum of the pons. Histology again reveals these plaques by the absence of their staining with myelin. This is a schematic view showing the different stages of disease activity in multiple sclerosis. So we tend to talk about the plaques being active, inactive, and then there's a third morphologic appearance called shadow plaques, which I'll discuss. And shadow plaques just show the process of demyelination and remyelination, which can occur in the same plaque. So the top shows normal white matter, while the middle panel shows an active process of demyelination, which is characterized by perivascular and parenchymal lymphocytic infiltrates with macrophages. As we'll see in some of the upcoming microscopic images, the macrophages frequently are distended by the lipid material from the breakdown of myelin. The bottom panel shows inactive plaques, in which there's gliosis, as well as loss of axons. And those axons that are present show degeneration, kind of analogous to Wallerian degeneration that we see in the long spinal tracts. This is the edge of an active plaque, which shows a poorly defined edge of active demyelination, which you can see by the absence of myelin in this area, contrasting with preservation of myelin in the upper right corner. This is a silver impregnation stain, which stains the axons, and you can see that even in this area of demyelination from the previous slide, there's still relative preservation of the axons, and of course there's more preservation of axons where the myelin was preserved. One of the histologic features is the accumulation of foamy macrophages at the edges of the plaque. So you can see all of these cells which have faint purple dots in them are macrophages that contain ingested myelin breakdown material. To the left of the slide here you see relative preservation of myelin, which stains dark blue, or what's called luxophilic, because the stain is called a Luxol fast blue stain. Just to confuse things, we pathologists call these luxophilic material. This is a routine H&E stain slide that we're more used to seeing, showing these reactive astrocytes with homogeneous abundant eosinophilic cytoplasm. Here you can see the star-shaped appearance of the cell. There's even a multinucleated cell, again emphasizing their phagocytic function of all of this myelin material. Another feature of active plaques are perivascular and interstitial lymphocytes, So you can obviously see the accumulation of these small dark lymphocytes around this vessel, as well as they're sprinkled throughout the adjacent plaque. This is an immunohistochemical stain for T cells showing that the vast majority of these perivascular lymphocytes are T cells, as well as in the interstitial lymphocytes as well. So this is a handy stain to identify the lymphocytic infiltration, particularly in the interstitium. One of the characteristics of active plaques are variation in disease activity. So there's marked variation in the density of the cellular infiltrate if you compare this relatively hypercellular area of plaque with the hypocellular area adjacent to it. This is another myelin stain. So both areas show loss of myelin with a band here of relatively preserved myelin. But the point is that there's variation in disease activity. And again, this reflects the pathophysiology of demyelination and remyelination. Another example showing again this variation in disease activity. This is a chronic plaque with a hypocellular center, and the edge shows an area of densely cellular active demyelinating periphery. So you see preservation of myelin here at the edge of this plaque, and then this whole area is demyelinated, but it has this hypercellular band at the edge. This is a microscopic example of these shadow plaques, again emphasizing this process of demyelination and remyelination. So you can see that there's this completely demyelinated area off to the right, and of course the dark purple shows the area of preserved myelin, and then this shadow area in between, which is kind of intermediate between complete demyelination and complete myelination, and so it's given this name as a shadow plaque. Another type of stain showing myelin, again with these areas of demyelination and myelination with a shadowy area that shows intermediate myelination. Inactive plaques basically reflect a burned out, scarred area of plaque. So the main features are demyelination and gliosis, or astrocytosis, if you will. Even in inactive plaques, there is still some relative preservation of axons, even though they are reduced in density, and if you compare them, they're much thinner or attenuated compared with the area myelinated area to the upper and right part of the image. So hopefully you're not too confused with the rundown of the pathologic changes that we find in MS. I'm going to review these briefly for you now. Grossly, we have well demarcated regions of gray discoloration or depression. They vary in size, shape, and number as well as distribution, but can occur anywhere in the white matter. They're frequently present in the optic nerves and often present adjacent to the lateral angles of the lateral ventricles. However, they may occur anywhere also in the cerebellar white matter, brainstem, and spinal cord. You'll need to distinguish between active and inactive plaques in terms of microscopic pathology of MS. So active plaques are hypercellular lesions. They have dense perivascular and parenchymal lymphocytic infiltrates with macrophages and scattered astrocytes. You'll find numerous foamy macrophages at the edge of plaques, while most axons are relatively preserved even in the demyelinated areas. Inactive plaques, on the other hand, are hypocellular lesions. They're densely gliotic or scarred, often with loss of oligodendrocytes. The plaque margins are sharply defined, by myelin stains anyway, and there is axonal loss. They are reduced in density as well as shortened. And finally, shadow plaques are an intermediate lesion in which the myelin staining shows reduced but not absent myelin. This reflects the process of demyelination and remyelination that occurs in conjunction with the relapsing clinical features of the disease. You can find these shadow plaques either repeatedly or concurrently within the same plaque. So hopefully this is how you feel now that you're contented and happy knowing the pathology of MS. And so the next talk, I'll talk about some of the differential diagnoses that you have with other demyelinating or dysmyelinating diseases. Thanks.